afferent arteriole. Where? This is Bowman's capsule. So here it is afferent arteriole. There are cells, right? Endothelial cells of these arteriole. What it releases?
Nitric acid.
It will release renin. Renin is released. When renin is released? When there is blood pressure gets down. If it decreases, this renin is released. How this renin is released, that also I have said, but still I'll just repeat it. See. This is a nephron, okay? So here, this is DCT. So in DCT, what cells they have? Yes? What are the cells? What are these cells? These cells name is juxta glomerular cells. These are macula densa cells, right? Macula densa cells. What these macula densa cells will do? These macula densa cells are the taste cells. When there is pressure less amount of filtration and more amount of reabsorption. So less salt will come here. Here very less salt will be there. Because all things got reabsorbed. So this will not have salt. Immediately they find that there is no salt. What they do, they along with this juxtaglomerular cells and macula densa cells together release renin. Now renin is released. When there is less blood pressure. So this renin will flow in the blood. And in blood, always there is one enzyme which is released from the liver. It is flowing always in the blood. That is called angiotensinogen. Angiotensinogen. Angiotensinogen is present in blood. When the renin is released, they act on angiotensinogen and they break the angiotensinogen to angiotensin 1. Now angiotensin 1 is formed in the blood. Okay. So this angiotensin 1 will again circulate in the blood when it goes to lungs. In lungs, there is another enzyme called ACE. What is ACE? Angiotensin converting enzyme. This enzyme will convert angiotensin 1 to
angiotensin 2.
Yes, angiotensin 2. What is this angiotensin 2? Angiotensin 2 will have three main effects. One is it is a potent vasoconstrictor. Okay? Because blood pressure has decreased. Once there is constriction of the blood vessels, what happens to the blood pressure? Increases. Because it was decreased. By release of these, with these, finally angiotensin 2 will have vasoconstriction. Alright? Directly there is vasoconstriction. There are three methods with which it acts. It will go and release aldosterone. Where aldosterone is released? Aldosterone is released in the adrenal cortex, in the adrenal gland. Adrenal gland is present on the above the kidney. Okay, and above the kidney, this aldosterone which is released, what this aldosterone will do? This will have vasoconstriction action is decreases the peripheral resistance directly onto the blood vessels. But this aldosterone will increase this DCT, iron collecting tubules reabsorption. Okay, so as more and more salt is absorbed, reabsorbed, water also comes. Along with sodium, always water comes. So what about the volume? Volume of blood increases or decreases? Once when it is reabsorbed more, yes, the volume increases. As volume increases, blood pressure
High.
increases. We started with decreased blood pressure. One way it is increased by decreasing the peripheral resistance, having vasoconstriction. Another is aldosterone. The third mechanism by which it acts is it will circulate and goes to the pituitary gland, posterior pituitary gland, where it releases ADH. What is ADH? Anti-diuretic hormone. Anti-diuretic. What is diuresis?
Tension of
What is diuresis? Diuresis means more urine. Urine output increases. That is diuresis. So to decrease the blood pressure, we give diuretics, right? Thiazides, hydrochlorothiazide, furosemide, all these why we give? To increase the urine output. As urine output increases, blood volume decreases, right? That is how we are doing. Now this is anti-diuretic hormone. This hormone is anti. Anti means what? Against the blood loss. Against the water loss. So this will increase. There is aquaporins which are formed. So with that aquaporins, it returns. It takes all the water so that less urine will go out. Volume increases. Same. Once the volume increases, what happens to the blood pressure? Blood pressure increases. Ultimately, the decreased blood pressure has increased in two ways. If the blood pressure decreases, our auto-regulatory mechanisms will increase the blood pressure. If the blood pressure decreases, it will increase. If it is increased, it will decrease. By making it balance. That is natural. So this is the pathogenesis. Now we have now known this. By knowing the regulatory mechanism, we can use the drugs. If we use diuretics, what happens? That's a first line drug, especially for elderly patients and for diabetics. For many persons, diuretics are the safest medicines. One can go with these diuretics. Geriatrics, we can go with diuretics. So these diuretics increases the urine output, thereby volume decreases. So this mechanism, it will act directly so that we can use drugs. Diuretics we have learned in antihypertensive drugs. I have read the classification completely. There you can see there are vasoconstriction. So direct vasoconstrict dilators we can use like hydralazine, sodium nitroprusside. I told whenever the blood pressure increases, we cannot give directly the drug. We have to wait to the patient till it will be in a what range, after knowing of a week or 2 week, or in even they say up to 6 months to wait before starting of the drug. But in hypertensive crisis, we cannot wait for the patient to give the drug or not. No, immediately we have to treat. So immediate is direct vasodilators, where it acts on this constriction. Okay, and there are other drugs with which this angiotensin 2 should bind to its receptors to act the vasoconstriction action. So binding of that receptor, if our drug, what we are adding, that is binding, then this is free. And there is no vasoconstriction. There is no blood pressure increase. So we can decrease the blood pressure. So angiotensin receptor blockers that we can give. All TANs, losartan, telmisartan, all these drugs acts. That is how we can decrease the blood pressure. Then we can decrease the renin action, which converts angiotensinogen to angiotensin 1. alcacerine, that is the drug where directly we can inhibit. Once this is inhibited, all these mechanisms will decrease. That also we can give. Very good, this drug, ACE inhibitors. What do you mean by inhibitor?
रोकने वाले stop कर
Yeah, inhibit means to make it not to have that action. If we give a drug, the drug will bind to this enzyme, ACE, angiotensin converting enzyme.
Yeah.
This enzyme, if it is binding, then there is no enzyme to make angiotensin 1 to angiotensin 2. There is no formation of angiotensin 2 because our drug we are using all prils, captopril, enalapril, ramipril. So all these drugs will act so that there is no angiotensin 2 form. So that is how we are decreasing the blood pressure. That is what the pathogenesis of hypertension is. So in that way, we can even deal with the drugs. So this is an overall picture of pathogenesis of hypertension. Yes.
एक बार बीपी की टैबलेट चालू करने के बाद अपन बंद कर सकते हैं क्या? या till the life we have
No,
to take?
we can. As such, we cannot because of our lifestyle. Can we change our lifestyle? Once we know that we got blood pressure, we will not change. We will change temporarily. Oh, today it was known that my blood pressure is increased, so from tomorrow onwards I'll go with the cautious with the diet. I'll go with all my lifestyle changes. I'll go with the exercise. Everything he will make a plan.
Psychological.
Whether he'll keep that for throughout his life, it is not possible. That means what is possible? A pill a day can make everything possible. So that is how we are with the drugs. We can avoid drugs until unless we should have that courage to do all changing our habits. If it is changed, then we can correct it.
But hundreds of patients, I had hundreds of patients who जो है बीपी की दवाई बन गया है सर दोस्तों। जब मैं सेना नमक जो आता है ना,
Yes.
रॉक सॉल्ट, येलो कलर का लाहौरी नमक, वो S1 स्टेंट से hundreds of patients को बीपी, मैं 3 साल हो गया, मेरी बीपी भी नॉर्मल रहती है,
Yes.
मैं कोई टैबलेट नहीं है। It is harm or not?
Because a person who has known that he is a hypertensive patient, until unless he check his blood pressure intermittently, constantly अगर वो check कर रहा है, then if it is normal, there is no problem.
Okay.
For him, there is no need to have drugs. If at all, in any case, if the pressure is high, he has to again consecutively observe for 1 week, then finally he can go or not, he can decide.
डेली रूटीन में कभी भी स्ट्रेस आए तो चल रहा होता डॉक्टर साहब।
Yes, that is what. Directly stress is related to hypertension. Why stress is related? Now I'll come to that point. Because these are the drugs, there are other drugs. Those drugs are called sympatholytics. Sympatholytic drugs. What are sympatholytic drugs? Lytic means against the sympathetic activity. What is sympathetic activity? It is fight and flight mechanism. When we want to fight, when we want to run, when we want to have fear, when we want to have emotions, when we get stress, what happens? Our sympathetic activity overtakes. That increases. Once sympathetic activity increases, what happens?
बीपी इंक्रीज।
Heart rate increases, blood pressure increases. We want more and more energy. Pupil gets dilated because we want to see the situation, we want to correct, and we want to run away. So that is what the sympathetic activity is. So we can decrease the sympathetic activity by giving drugs called beta blockers, alpha blockers, alpha beta blockers. So these are the drugs with which we can control blood pressure. Even we can give calcium channel blockers. Calcium channel. So the entry of calcium is the main component for depolarization. If depolarization is not there, relaxation of blood vessel. As relaxation of blood vessel, no blood pressure increase. So this is how we will correct ourselves. So how stress is related to blood pressure. So we can decrease by giving the blockers. Okay, not to have increased sympathetic activity, not to have more cardiac output, not to have more peripheral resistance. As dilatation, peripheral resistance decreases, blood pressure decreases. As blood preload and afterload decreases, less amount of blood, easy to pump, there is no need to have constriction, so blood pressure decreases. Okay, this is about the blood pressure. Now we will go with anti-anginal drugs today. Okay, if you have still more doubts, we can clear it when we meet again. Okay, today's topic will start. In short, in brief, I will take for 15 minutes only. Drugs are the chemical substances which we can use for various purposes. Here the purpose is angina. What is angina? Angina pectoris. Angina is the pain. It is the pain. It is the radiating pain which starts in the chest. That radiates to left hand, even to scapula. The whole chest with the left hand pain. It is called referred pain because the pain is starting from heart, but it is recognized as the hand. So the nerves where we have are referred pain. So that is called angina pectoris, to the pectoral region, pectoral girdle. Okay. So angina is a pain. Why we get this pain? Now we want to know what is pathogenesis of pain. Pain is because we need to work. We need energy. Without energy, if we work, what happens to us?
Blood circulation.
We get tired, right? We get pain. We cannot do that work. Same way for heart also. Heart needs what? Oxygen to work. Myocardial cells needs oxygen. That oxygen supply will not be there to heart. To pump the blood to all parts of the body, it also has one oxygen from coronary artery. From coronary artery, if the oxygen is less supply, so we get a pain. That is called anginal pain. So here what happens? Oxygen demand increases. Supply of oxygen is decreases. As supply of oxygen decreases, demand increases. As demand increases, the person is already suffering. Suddenly, again, if you want more oxygen, what will happen? He cannot get. So there will be a pain. So that is called anginal pain. Now, I'll show you in a diagram wise so that you will understand how this anginal pain starts. Blood from pulmonary arteries, veins, it comes to heart, right? Yes, heart. So this oxygen again will be given to where? To body, right? All parts of the body. Pumps. Heart pumps and delivers. Same way that heart, even it pumps and delivers to coronary artery also. So this coronary artery, myocardial cells needs oxygen. Here all body needs, all cells needs oxygen, right? So when this supply is not there, especially to this area, if there is no oxygen, if there is no blood, no oxygen, anginal pain we get. So this part is another one. This is pertaining to the heart itself. Function of the heart is decreased because of not having oxygen supply. Is anginal pain. Okay? Right. So CAD, what is CAD?
Coronary artery disease.
Artery disease. So this coronary artery disease makes this oxygen demand to get increased because supply is decreasing in coronary artery disease. Coronary artery is not functioning properly. It could have two things. CAD has two things. One is a plague. Plague is formed. What is plague?
Atherosclerosis.
Sclerosis. What is atherosclerosis? See, this is blood vessel. Here atheroma is formed. This atheroma is hindering the blood to flow. So what happens to here? As the blood is not flowing properly, oxygen is less to this area. So this could be one reason. The other one is spasm. Vasospasm. What is vasospasm? Due to some reason, there is spasm of the coronary artery. पिचक जा रही है, right? So in that way also, it is easy for blood to pass? No, there is hindrance. So these are the two reasons why we get angina. Okay, basically it is for coronary arteries where either plague or atheroma or by vasospasm it occurs. Okay, now coming to the risk factors. Why this happens? Why is very big question, right? Why this happens? It could be because of hyperlipidemia. What do you mean by hyperlipidemia? Mia means it is to blood, right? Where more lipid in the blood, like lipid deposition, if it is more, in turn it increases blood pressure and oxygen demand to the heart again increases. So this could be one reason. Another is hypertension. Even hypertension causes angina. Then diabetes. Even diabetes also. Diabetes has direct relation with heart diseases. They are brother and sisters. Okay. And then smoking causes even angina. Then weak lifestyle and family history. A person is very good. He's doing exercise. He's doing everything. Suddenly by myocardial infarction, he died in the age of 45 years. Everything was good with him. What happened? So is that life? We say we have to take care. We have to change our lifestyles. And see, that person, it has happened. So what is the use of doing that? No, that could be a hereditary cause. So hereditary plays an important role. Okay, even with his genes, because of that, he got these things without any, by having all cautious things, could also lead to angina. So even hereditary, that is family history, is also very important. These are the risk factors with which one can get angina. Now, what are the types of angina? We will see. We have three types of angina. Mainly, there are three types of angina. One is stable angina. Why we say stable, that I'll tell you. Another is variant angina. Third is unstable angina. So these are the three types of angina. Stable angina, variant angina, unstable angina. We will see one by one each type of angina. Stable angina is called classical angina. Even it is called classical angina. This occurs in 3 to 5 minutes only. The pain will be for 3 to 5 minutes. Then the person will be normal. Nobody knows. He'll turn to a normal life. But the pain will be for 3 to 5 minutes only. This is called classical angina. Why it is called classical angina? Because this pain is because of exercise. So what happens in exercise? Already there is a plaque form, so less oxygen is passing. When he do some work during exercise, his oxygen demand is again increased. Already he is struggling with less oxygen. Once when he do some extra work, The oxygen is again he need more. From where he'll get? Already he has less oxygen. So that time, if we get an angina, that anginal pain, that is called stable angina, classical angina. Okay, most of the cases will have this classical angina only, stable angina, and it is curable. We can cure this. Once we know, we can give the drugs where plaque form is decreased. Antihypertensive drugs we can give, antihypertensive drugs we can give the drugs where the preload and afterload decreases, heart work decreases, thereby sympatholytic drugs. So we can, all antihypertensive drugs we can add here in this class, and we can treat this anginal pain. Okay, so work for the heart increases, so the demand increases, which we can decrease. The first one is classical. The second is variant angina. It is also called Prinzmetal angina. So here, vasospastic. It is, another name is vasospastic. What do you mean by vasospastic? I told vasospasm. What is vasospasm? There are two types of. One is the plaque form. Another is. Yes. Due to this spasms, variant angina occurs. So if at all the diameter of the coronary artery decreases, it itself, that time we get a anginal pain, that is called variant angina. This variant angina is uncommon condition. It is not a common, this type of angina. Vasospastic angina is uncommon. It occurs during sleep, suddenly. Morning, when we see that person is not waking up, he may be having this variant angina, spasms. Because of this spasm, he could not get the oxygen to that particular area, and that tissue has dead, and myocardial infarction, due to that death occurred. So this is uncommon, but during sleep, it is dangerous. It is not good. Working person, we can stop him, don't work, he will not have angina. But for this person, where we can stop? Simply sleeping, and he'll sleep for lifelong. So that is variant angina. Even this unstable angina is also. What is the difference between stable and unstable? This unstable angina will be from 10 to 30 minutes. The pain is longer time. That is the main difference. That is why it is unstable. With this much, okay, one can bear. But this much, it is not possible. If this much time, if the oxygen is demand increases, then that tissue has to die. It will not recover. He cannot come back. So that is unstable angina. Unstable angina is a serious condition compared to stable or classical angina. So what we have to do, even this also occurs when there is rest. The person is in rest, suddenly it happens. Without any signs and symptoms, without any signal, suddenly this happens. And it is prolonged for longer time. So one has to be very cautious with unstable. It is rare, it is not very common. The common is only stable angina. It is uncommon, and it will be up to 30 minutes, where it increases the duration of attack, especially during night, and plaque gets ruptured. What is the difference? Here, this is what the stable we have seen. This gets ruptured. If the plaque gets ruptured, the deposits will circulate in the blood, right? Once after Azan, we'll continue. Just we'll have a break.